my dear friend and colleague, Dr. Masoumi, who's going to be joining me starting in September, building upon an already excellent program that they have at Morristown Medical Center, and try and build their complex PCI/CTO PCI program and the mechanical circulatory support. He's going to talk to us on how to build a successful CTO PCI program. Amir.
Hi, thanks for your kind introduction and this invitation. I'm going to talk briefly about how to build a CTO program, which Darshan touched upon in his conclusion remarks. As he mentioned with the literature review, CTO procedures are beneficial for patients in these regards: relief of symptoms, improvement of ventricular function, more and more we're learning about that, reduced incidence of late cabbage referrals, and improvement in event-free survival. However, when we are talking about program building, we need to have allies with the institutions and administrations, because that will determine the success of any initiative and program. What are the benefits for the institutions and administration is the name recognition, branding, positive economics. I think Dr. Karmpeliotis decades ago showed the benefits and the revenues that CTO programs will bring to the hospitals and institutions. But we need to remember, as the technology is improving, we'll have more ancillary testings, ancillary services will be involved, heart failure team, for example, cardiothoracic surgeons, vascular surgeons. So we'll have more of a concentrated, higher level care that will ultimately improve the patient satisfaction, and they will have all the care in one place. Also, it will increase the procedural volume and referrals, and in reduction in readmissions. So there will be a mission, and that mission is that these are higher risk cases with the greatest complication, and they're least desirable to be intervened upon. But if we promote a complete revascularization with indicated hemodynamic support, which these two are the pillars of CTO programs, we'll see the benefits for the institutions, but ultimately for our patients. Regardless, what we've learned from most of cardiology, but more specifically from the valve team approach, is a team approach. And that team approach or heart team approach needs to have experienced interventional cardiologists, cardiothoracic surgeons. This is a bi-directional partnership, which is crucial. We need, adequate cardiac cath lab environment and staffing. We need mechanical support backup, imaging and specialized testings, and also critical care, both nursing and specialists, which will ultimately dictates the success of the program. And with support of administration, we'll be able to not only build, but develop and progress the program. In terms of the administrations and how we try to identify the gaps, we have to see what are the flaws with the current care delivery. First of all, we need to identify our capacities and capabilities. This is not for every single cath lab or every single institution. So we need to identify those. And then we should remember, it's not only for CTO or complex PCI. In general, it will elevate the overall quality of optimum PCI. And that's what should be the message for the entire cath lab and patient care. Then we need to identify what are the costs. Equipment, cath lab time, turnover will be longer. We need to have skilled team members. These are definitely, the retentions are a little bit more costly. We need ongoing education that will add to the cost. We need coordinators, additional staff that are not only familiar with the procedures and, and the needs, also they will be in direct contact with the referrals, educating the community and our patients. And also we need marketing targets. And also we need to know what are the potentials for increased reimbursement. This has been done before, and we have our TAVI programs as a great experience. In terms of the team approach, we need to train specialized physicians. These are the ones that are familiar not only with CTO procedures, but also how to manage complications, how to address the patients, how to talk to the patients prior to the procedures, and have like a educated and a collective decision with patients and families at the center. We need to have dedicated CTO days, designated complex PCI rooms. The environment, it should be spacious enough in case of complications that other teams need to come in. Safety and radiation is another one that Darshan touched upon, and we need to appropriately stock the rooms. We need dedicated cardiac cath lab staffing. As I mentioned, retention is important here. Huddles and pre-procedural planning, it's crucial, because it's not only the operator or the assistant, it's the whole team. Our nurses, pre-post procedure, everyone should huddle and know exactly the game plan and know what are the strategies, plan Bs and bailouts, complications, and how to address those. And also briefing, that's very important. We need to review our cases. We need to learn from our mistakes and our victories. And also we need to have a systematic approach with quality measures as well. And also in terms of educational and academic environment, we need to have M&Ms, and hopefully everyone will be elevated and learn from the strategies. So in conclusion, the ultimate goal is to improve patients' outcome. But we need to identify the gaps. We need to know our capabilities and create opportunities. We need to have a team. This is not a one-man show. We need administrations. We need good partners within different different disciplines, medical disciplines, ancillary teams, cath lab staff, and coordinators. And these are the novel skills that also we need to learn. We are physicians, but we need to learn business planning, how to do good marketing, and this should be evidence-based to educate the patients and the families and the referrals, and we need to learn how to manage our team members. Thank you.
It was a very good and comprehensive talk touching on all aspects of how to build a program, and as you said, that extends beyond CTO program building, but complex PCI, mechanical circulatory support, shock, advanced heart failure, interventional heart failure, and so on. So if Arun is on board and can hear me, Arun, you've been one of the most skillful operators I've worked with, and I would like to ask you briefly, within 20 or 30 seconds, to tell me what data do you think that we need, not to convince only ourselves that we're doing the right thing, but also to convince the broader interventional and cardiology community that opening up a CTO is beneficial to the patient and safe?
Oh, first of all, fantastic talks, and thank you, TCT in India and TCT and Dr. Srinivas Kumar in particular for having me involved. I mean, it was kind of touched upon in the previous talk about, essentially getting hard outcome data. I mean, I would love for that to be shown, but I'm kind of skeptical if we are ever going to have a large enough trial to actually see, real hard outcomes and a reduction due to CTO PCI. I mean, due to all the reasons that we already know about. Now, if we can convincingly show people that we are reducing ischemia and symptomatic improvement, in a good, well-designed stuff, and then, kind of set this to rest. And I think symptom relief is a lofty enough goal. That's one. And the other one I would say is that in the impaired EF patients, many times when we have shown viability, if you can show convincing, that might be a population where you could show like either improvement in EF or any of the surrogate outcomes that might show that these would translate into better hard outcomes, I think then we'd have a better job of convincing our partners that don't do CTOs.
Thank you. And I would also say that we need to prove and do our best to make sure that we make the procedure safer. Because over the last few years, I don't think that we have moved the needle the right direction. If you look at more recent CTO trials, either the registries, single center registries, or multi-center registries, still the complication rate is an issue, and we have to work a little bit harder on this. And Dr. Surapakars, are you on? Is Dr. Surya Prakash, I'm sorry if I'm correct, mispronouncing, is he on the panelists? Or Dr. Kapardi?
There was some confusion. Actually, I was in another room, and then I don't know. I actually re-logged in, and that's how I got here. So I'm not sure if they've been sent to the other room for whatever reason. So I will.
Is Dr. Parshur or Dr. Damodar or Dr. Kumar among the panelists? This is the list of panelists that I have.
Dr. Arun, you are in the right room. Yeah, I think, Dr. Dimitri, we can move to the next presentation.
Okay, I just had a question for Arun then. Just 10 seconds. What is the biggest obstacle based on what we heard from Amir in order to build a successful CTO PCI program? Just 10 seconds, please. If you had 1, 2, or 3 things to say.
So, in India, I think there are a lot of myths surrounding CTO PCI. The one that we talked about, the collaterals, it was in the talk before, what IFR. Thinking that collaterals still are enough to reduce ischemia and symptoms is probably the biggest misconception, I would say, in this part of the world. And of course, the other one that, you kind of hit the nail on the head about safety and saying CTO PCI is dangerous, which, it is compared to regular PCI, it has a higher, peri-procedural risk rate, but it can be done relatively safely under expert guidance. I think it's still a concept that needs to be bought out here. I would say those are probably the biggest two.
The only thing I had to add is that when we talk about high-risk PCI, if we see the complication rate, for example, in SVG PCI or rotational atherectomy, the numbers are not that vastly different.
Yep.